Hello, welcome to the Newborn Screening Forum, the second one for the year. This one's on biotinidase deficiency, and we're really pleased to be here to talk about biotinidase deficiency, which is our newest condition that is fully accredited and introduced last month into our screening program formally. I'd like to take this time to acknowledge the traditional elders of the lands on which we're meeting and pay my respect to them and also to the present and emerging elders. This evening we will be hearing a little bit from myself, and my name's Rhonda Greaves and I'm a clinical scientist within the Newborn Screening Program in Victoria. We're very fortunate to have Dr. Lenisa Harmony, who we'll know lovely as Leah, and she is from the RCH Metabolic Service. So Lenisa is a paediatric medical specialist, metabolic specialist at the Royal Children's Hospital in Melbourne. She's been working in the field of genetics and inborn errors of metabolism since 2012. She's passionate about improving outcomes for metabolic patients diagnosed through newborn screening. And I think quite importantly here, we're the first in Australia to be introducing biotinidase deficiency. So we're really privileged to have Leah present because she's got experience from the Philippines where they have been running biotinidase deficiency for many years. And so we'll hear some of her background and patient experiences. This is a wonderful opportunity to have Leah with us, and I thank her for being involved. Now, an oldie but a newie as well is our lovely educator, Holly McNamara, and she's our newborn screening educator. She's been with us for almost a year, and she'll be presenting on just some updates on education that are really timely associated with biotinidase deficiency and the expansion of newborn screening. So to go with these presentations, and these presentations will go for about 45 minutes, about 15 minutes each is what we're anticipating, and we'll have time for questions. And there's a Q&A button in your session that you'll be able to go to add questions. And we've got a couple of helpers in the background, Dr. Joy Lee and Dr. Mercy Thomas, who are from our newborn screening team, and they will be helping to moderate those questions and also telling me if I'm doing any goofs, which we hope I don't. Now let's move on to the learning objectives. For this evening, we've got 3 learning objectives to complement what we're talking about today, but it's all about the baby ultimately. And by this time, we're focused on the clinical of biotinidase deficiency and how you might talk to new mothers and about screening for this condition. We're also going to talk about the potential impact of some poor sample collection on this expanded newborn screening that involves biotinidase and other conditions. And I'm going to do that in a moment, and to be able to explain the importance of timely newborn screening and the clinician's role in supporting this timeliness. So I've presented this slide at the last forum also. So we're in the state of Victoria. We have around 80,000 births per year. We're testing about 85,000 samples per year. In Australia, we have about 300,000 births, and in New Zealand, that might make up another 50,000 births. So the Albanese government a few years ago now decided that they were going to get involved in newborn screening and end the postcode lottery, as they called it, with their election pledge. And they wanted to standardise and harmonise newborn screening across Australia. And they've been really quite successful with this, and I will show you some of this in a moment. But what they've also been doing is trying to have a standard approach to deciding on whether new conditions should be implemented and looking at how the different jurisdictions in Australia, which are 5, implement them. So this harmonised expansion, and this is off the Commonwealth website, is actually running at the moment. And so you can see at the top of this list, we've got biotinidase deficiency, a condition screened. It was approved by the health ministers on the 6th of February 2025, and Victoria is the first to implement it. So this is really good news for us. It's one that we've got ticked off the list. And if you go down the Victorian pathway on down the column, you'll see we've already got GAMT deficiency. And this slide will be updated in the next few days because we started sickle cell background work last week. So there's a lot happening, and all the states and jurisdictions are working really hard. This has impacts for the maternity service providers as it has impacts for the laboratories running the tests. So in Victoria, we have a setup where we have the old way we did it when we only had a few different conditions that we were looking for. We had about 25 and we would punch 3 spots from a card, and I'll explain that in a moment. And so it was kind of a simple flow path. And then what's happened now is we have a far more complicated flow path, a lot of different instruments. We've got PCR, we've got mass specs, a whole heap of things that you probably don't care a great deal about necessarily, but it becomes a more complicated laboratory. And newborn screening is becoming more complicated within the laboratory as a result. And so when you send the cards into the laboratory, we've got background information for specimen collection and how sample collection guidelines. And we have updated these as we've expanded our conditions. So as we've needed to take more sample out of these blood spots to cope, we've updated our advice on how many spots are needed and changed this. We've also provided a collection video on how to collect, which was a new video done in conjunction with the Royal Women's Hospital. I'd like to take now just a little step into the lab. So what we have here and is a sample, just 2 blood spots that are actually blood on them out of the 4 here, but they're nice big blood spots. And so if we had 4 tests that we were doing, we would be punching out 4 little discs out of these blood spots, as you can see by these holes here. And they're 3 microliters in size equivalent. But you can see that's what we would take. And we have someone on our puncher here, and we can see that we've got the card in our instrument, and this is photographed, and the instrument actually recognizes where the blood is and punches it. So in this case, on this particular spot, it can actually find 8 different punches to take out because we're doing 8 tests at a time now. So that works really well, and it's a great size spot, an excellent collection with that size spot, and so we can get a lot out of it. What happens when we have a smaller spot size and we have the punches coming out? So this is on a different card, and in this case we've got 4 punches, and you can see it's taking up more of the blood spot. We put this on an instrument on the same puncher, and we zoom in, and you can see those 4 positions actually take up most of the spot. So we already have to go and find more blood from a different spot that's been done. So what's actually happened here is that we're getting a few more samples where we're going insufficient and asking for, needing to ask for a recollection. So I just thought I'd show you that process as we walked our way through what we're talking about tonight and the effect of this expansion on some of the work we're doing and why we're asking you for more sample. So I hope that was useful. And now it's over to the real story for this evening, which is to Dr. Leah Harmony and to her presentation on biotinidase deficiency. And I thank Leah for being here.
Thank you, Rhonda. So, this talk is all about biotinidase deficiency and the relevance of it being added to the newborn screening program. So, let's remember again what the premise of newborn screening is. It aims to detect rare but serious conditions early, so before the symptoms appear, hopefully, so that we can start treatment and prevent lifelong complications. Biotinidase deficiency, I think, is the perfect example of such a treatable metabolic condition. So the goal of this talk is for us to gain an understanding of what biotinidase deficiency is, to identify its signs and symptoms in untreated patients, and to appreciate the importance of early diagnosis and treatment. So before we look at biotinidase deficiency, let's briefly talk about biotin, also known as vitamin B7. Biotin is a water-soluble B vitamin that's needed by particular enzymes for protein, fat, and carbohydrate metabolism. Food that contain the most biotin include cooked eggs, fish, meat, seeds, nuts, and certain vegetables such as sweet potatoes. And this is the interesting thing. So, our bodies also recycle biotin continuously through a pathway called the biotin cycle. This is the biotin cycle. Here we see how biotin activates important enzymes called carboxylases. They're involved in the metabolism of proteins, particularly protein breakdown, fat synthesis, and production of glucose. And the specific enzyme names are here below, but we don't need to remember them all. Now, a recycling mechanism then ensures that there's sufficient biotin to be used by the enzymes again, even if we only ingest a limited amount of biotin through our diet. This recycling mechanism depends and relies heavily on this enzyme called biotinidase. So if biotinidase is absent or reduced, biotin cannot be effectively reused, and so a functional biotin deficiency develops. Again, even if the diet is normal. This is biotinidase deficiency. So that means that the carboxylases or the enzymes will not be able to function properly, leading to energy deficits, buildup of toxic chemicals, and insufficient products, say, for example, your fatty acids, right? And that leads to a variety of symptoms, mostly affecting the brain and the skin. Worldwide, the incidence of biotinidase deficiency is about 1 in 60,000, with an unknown prevalence in Australia. But newborn screening will help us find the true local prevalence. So there are two main forms of biotinidase deficiency. One is profound deficiency, where enzyme activity is less than 10% of normal. And then we have partial deficiency, wherein you have 10 to 30% of enzyme activity. Now, if untreated, profound deficiency can cause neurologic signs and symptoms such as seizures, hypotonia or low muscle tone, hearing loss, which is sensory neural hearing loss, can actually also have visual problems, developmental delay, and then dermatologic symptoms such as rashes and alopecia. Now, the onset of these symptoms is usually in infancy, as early as the first week of life, usually around 3 to 5 months of life. But then they can actually also be as late as the third decade. So there is a late onset type as well. For the partial deficiency biotinidase patients, it usually remain silent, but can present during stress such as infections, trauma, when patients undergo surgery. So they're usually the milder symptoms. But the aim of newborn screening is to detect the profound biotinidase deficiency patients. Okay, so I mentioned neurologic and dermatologic symptoms. Let's go over them in more detail. The most common neurologic features of individuals with untreated profound biotinidase deficiency are seizures and hypotonia. Seizures have been reported in more than 70% of untreated patients, and they can be generalized or myoclonic, but some children can also have focal seizures or infantile spasms. The sensory neural hearing loss and eye problems, such as optic atrophy, having a pale optic disc, they have also been described in untreated children. And approximately 75% actually have the sensory neural hearing loss. And the problem is that even when you've diagnosed them already and have started biotin, but if the patient is already symptomatic at that time with the hearing loss, that's hard to reverse. So it usually does not resolve or improve anymore, but it remains static though with biotin treatment. So there is still value, but it's proof that the earlier you treat, like if you treat pre-symptomatically, it's gonna be better, right? Many children with hearing loss can then be successfully treated with hearing aids, whereas others may require cochlear implants. Now, for older affected children, they can develop ataxia and developmental delay. Many children with biotinidase deficiency have abnormalities in brain imaging, such as delayed myelination or diffuse brain atrophy. Now let's talk a bit more about the dermatologic symptoms. Very prominent symptom is the rash. So it's been described as a periorificial rash. So it can be around the eyes, perioral, around the eyelids, periorbital, and then around the mouth, so perioral. The patients may also have alopecia, so sparse hair, sparse eyebrows. And then they can have a diaper rash that's therapy resistant. And they can also have candida, so candidal dermatitis that complicates that because aside from having the rash, these patients are also susceptible to candidal infections. You'll see the pictures here. So the sparse eyebrows there, the rash around the mouth, around the eyelids as well. A very prominent alopecia in this patient. Okay, so this is the late onset form, which has also been described. So it's where the enzyme activity is similar to profound biotinidase deficiency. So it's also less than 10%. But the symptoms are not the typical one, and they're seen later on in childhood or adolescence, even adulthood. So it presents differently. It's more of myelopathy, which causes spastic paraparesis, lower limb weakness, and then they can have optic atrophy or optic neuropathy with pale optic discs as well. And these patients have been misdiagnosed commonly with something like a juvenile multiple sclerosis type of picture. This table here shows possible laboratory findings, including abnormalities in the ketones, lactate, blood gas, ammonia, and organic acids. And then the confirmatory tests showing low enzyme activity and variants of the BTD gene identified in genetic testing. Treatment is lifelong, but it's very simple, very straightforward. Biotin is actually tasteless and it's very well tolerated. So the usual dose is 5 to 10 milligrams per day, but some patients may need a dose adjustment. So for some, we may need to go up to 20 milligrams per day, but still very easy. So with early and continuous treatment, children develop normally and they lead like healthy lives. So I'm showing you a couple of before and after pictures that are found in literature of patients who have been treated. On the left, you'll see the rash around the eyes and around the mouth, which resolved after treatment very beautifully. Unfortunately, what we cannot see in this photo is that this patient also had sensory neural hearing loss and optic neuropathy, which, as I mentioned, is not as easily reversible as the skin findings. But had he been diagnosed earlier through newborn screening, treatment could have prevented the hearing and vision problems. And this is another patient, again, illustrating how biotin treatment is very effective in particularly for the dermatologic lesions, but also very good in controlling seizures as well. Now to illustrate the value of good compliance, this patient was diagnosed and then was treated, but then had poor compliance with the biotin. So after the dermatologic symptoms resolved and the seizures resolved, when they stopped taking the biotin, she ended up having the symptoms again. And unfortunately, had sensory neural hearing loss because of that. So it's not enough to just diagnose and treat early. We have to ensure good compliance afterwards as well. Biotinidase deficiency is genetic. It's an autosomal recessive condition. So we have two copies of every autosomal gene. Both copies of the gene send a message to the cells to produce a particular product. And in this case, we're talking about the biotinidase enzyme. So if a person has two working copies of the gene, they have good enzyme activity, they will not be affected. However, if a person has two non-working copies of the gene, they will not have the ability to make enough biotinidase enzyme, and so they will be affected. Now, people who have only one copy that's working and one copy that's not working, they're called genetic carriers of the condition, such as these two and such as the mother and father in this illustration. So even though they only have one copy of the gene that's working and giving instructions to make the enzyme, that's already enough. They're unaffected, they don't show any symptoms of the condition. Now, when both parents are carriers, with every pregnancy, there's a 25% chance of having an affected child, a 50% chance of having a carrier child, and a 25% chance of having a child who's not a carrier, not affected. So why do we screen? I think it's pretty obvious at this point already, because early detection is definitely life-changing for them. So for symptomatic patients, treatment is really good at reversing skin and hair symptoms. It's effective in controlling seizures more than the normal anti-seizure medications are. It prevent neurological damage, it helps with overall development. But pre-symptomatic treatment, which is what we will benefit from with newborn screening, works even better because it prevents symptoms from even occurring at all. So that's particularly relevant for vision and hearing impairment, which may be difficult to reverse once it has already occurred. And yes, so biotin supplementation is safe, it's inexpensive, and it's cost effective. So in summary, biotinidase deficiency is a preventable cause of severe neurological disease. Its inclusion now in the newborn screening can help us diagnose the patients early, and early diagnosis allows treatment which is safe and effective, which is exactly why an expert in this field, so Dr. Barry Wolf, said, if you have to have an inherited metabolic disease, this is the one to have because it's so easily treatable. So that's it for my part for this evening. I'd now like to hand you over to Holly for her talk on newborn screening education.
Thanks, Leah. Thank you. Good evening, everybody. I'm just going to bring up my slides. Just bear with me. Thanks, Leah. That was really, really interesting and quite fitting with what I'm discussing today as well. So that's good. Hi, everyone. It's so lovely to be here tonight. Today, I'm just going to talk through a little bit about what Leah discussed in terms of the purpose of newborn screening and its importance, and especially touching on the timeliness of newborn screening and why that is so important. And I thought it would be a really good opportunity to kind of take a step back and go back to the basics and have a bit of a refresher on the why behind what we're doing and why we're doing it, as I think that's really important and drives our practice and the way in which we practice clinically as well as healthcare professionals. So the objectives today that I wanted to talk through are explaining the purpose and significance of newborn screening, recognizing the importance of timely newborn screening for optimal health outcomes, describing the clinician's role in supporting timely newborn screening, and applying the 5 rights tool to guide practice to support timely and effective newborn screening. So, as I said, take a step back, looking at the bigger picture. Leah mentioned it, so I won't keep repeating it, but the purpose of newborn screening is to identify those newborns that are at risk of rare but serious conditions and promoting timely intervention for them, which ultimately supports better long-term health outcomes. And our main aim is to protect newborns by reducing infant morbidity and mortality by recognizing these babies that are at risk earlier rather than later. And so timeliness within the newborn screening process is really, really important. And Leah put it well, is that, timely newborn screening can, change a child who is impacted, can change their lives significantly, as it promotes early identification and therefore early intervention for those that are at risk, which is crucial and key in reducing morbidity and mortality for those babies. As we know, some of these symptoms can appear late, and babies that are impacted can be asymptomatic for some time. However, once symptoms do appear, they can potentially have irreversible health implications that may already be present. So each step in the newborn screening process is linked. So it's important because delays at any point can impact the entire process and the efficacy of the outcome of the process as well. And so as clinicians, we play a vital role in the success of newborn screening and the timeliness of newborn screening as well. Our actions and our clinical practice ensures that newborn screening process is timely, accurate, and effective. So we play a very key role. And so we've come up with the 5 rights to ensure timely newborn screening, and it's a tool to help guide best practice in supporting timely newborn screening. So it's made up of right time, right documentation, right follow-up, right sample, and right delivery. So the first one is right time. And when we're thinking about timely newborn screening, timing of communication with families about the newborn screening program and its purpose is really important. And it should be discussed antenatally, post-birth, and prior to collection, as this supports informed consent and encourages program participation as well. So it's key to start the conversation early. The Department of Health guidelines outlines that the brochure should be given to families in the 3rd trimester and then discussed post-birth and prior to collection. But starting the conversation is crucial in terms of timely newborn screening. And also for timely newborn screening, the timing of the sample collection is also very, very important. So we're wanting to take the sample between the 36 to 72 hours after birth, and that supports accurate results, reduces the need for recollections, and ultimately prevents significant delays. Number 2 in the 5 rights is right documentation. documentation is crucial and key for timely newborn screening. Poor documentation can result in miscommunication, errors, the need for recollections, and, ends up in delays as we need to seek clarification and confirmation. And if there is some confusion, it may end up needing a recollection as well, which ultimately adds quite a significant delay. So we're wanting to make sure that we're documenting our consent clearly. If we are experiencing a family that are declining screening, ensuring that we're documenting that decline accurately and clearly, making sure that we're documenting in the baby's green book, we're signing the decline form and putting that in the medical file, and then also filling out the card as normal, ticking decline, having the family sign and sending it to the lab, as that piece of documentation is also key for us to be able to document on our end as well. And then just making sure when we're filling out the Guthrie card as well, that all the details on that card are really, really important. So making sure that we're writing legibly and accurately. And if you are, I just wanted to flag, if you're using a Bradma and you're covering up details on the Guthrie card, making sure that what you're covering up is actually recorded and detailed on the Bradma, because as I mentioned, all of the details on the Guthrie card are really, really important. And if we don't have the information that we require or we can't read it, it does cause a delay. And then just ensuring that we've got the correct postage details when we are sending the cards to the lab as well. And right sample, Rhonda mentioned it before and went through it, but high quality sample collection is also key in reducing delays and, the number of recollections we need. It also assists with accurate results and, the overall timeliness of the screening process. So making sure that we've got the 4 sufficient circles that are free from contamination, avoid layering and clotting, and just making sure that once we've taken the sample to just review what we've collected to identify any quality issues earlier. The next is right delivery. So we're wanting to send the sample within 24 hours of collection, express post or courier. Avoid waiting to batch a certain number of cards or holding on to samples. It doesn't matter if we receive one on their lonesome, just send to the lab as soon as possible, as prompt delivery keeps the newborn screening process moving and supports the timely screening and reporting on that sample for that baby. And lastly, right follow-up is also quite significant in terms of the timeliness of newborn screening. So making sure that we're managing declines appropriately and following up as necessary, and actioning recollection requests as promptly as possible. And then just keeping up communication with the lab in terms of relevant information regarding outstanding recollections, whether you've attempted to contact a family and you're unsuccessful, just keeping, closing the loop back to the lab is also really helpful, as actioning follow-up promptly reduces delays and supports timeliness. So the take-home messages for today, I really wanted to hit home with our purpose drives our practice, and the why behind what we do is really, really important. And, what we're doing is amazing work. So, just wanted to highlight that. And also timely newborn screening saves lives and promotes better long-term health outcomes. And clinicians are central and key. Their actions drive the success of newborn screening. And just remembering we've got the 5 rights to help guide us with the best practice. And lastly, I just wanted to say we're here as partners. Please reach out if you need support or resources or advice. I'm always happy to come out and chat and support you as best I can. Thank you. I think we'll go to question and answers now. I'd say, Rhonda.
Yeah, thank you, Holly. Thank you, Leah. That was lovely. Both of you. And I'd have to say that's the first time I've heard you talk on the 5 rights, and it's a poster that's coming soon to everyone, I think. So that was really lovely. Leah, thank you once again. Very interesting also just to see the effects of treatment and the effect of doing it early and the importance of that lifelong vitamin replacement. I've received a few questions, so I'll start with one that I might have to answer myself, but I'm happy for you two to give it a go. The question is about temperature and humidity on our dried blood spot samples. Is that for you, Holly, or is it for me?
I could probably do a little bit, but you would probably do it better. You do the sciencey side.
I do the sciencey side. Okay. So we know that dried blood spots, they take longer to dry in hot weather or humid weather just because it is humid. So we quite understand that. So that's why the amount of time actually varies in what we actually say. So I think we say, if I'm correct, up to 4 hours. But sometimes, depending on a drier environment, it can be a quicker drying time. So that's why it does vary. But what's interesting, what happens over summer to us, and we know this with our IRT test for cystic fibrosis, is that the results drop a little bit over summer. And so we have to adjust for that in the lab, and that works quite well. And the biotinidase is likely to be the same thing. So we haven't actually got to summer yet in Melbourne, so we're going to have to look at the effect of that change in temperature and the change in if we have humid days and what that might affect with the stability of the enzymes. So I think that was a really difficult question, but it's a really important one. And so we don't know what to expect necessarily yet with biotinidase because we've only started in the last few months, and that's been over winter. So we might see something different. I don't know whether you have anything, Leah, from the Philippines, because that's a hot, humid environment.
Yes, that's correct, Rhonda. And we have seen that it does affect the levels. So not only the heat, but taking a long time before the sample gets to the lab means that there's a longer time for it to be subjected to the heat, which could affect our results. So although we have no control over the heat, we do have control on the timeliness of sending the samples and all of that. So I think that's where we can make a difference. And the other thing is storage as well. So just making sure the proper way of storing it for biotinidase deficiency, it has been well studied and published that if you do store the cards in a plastic container before they thoroughly dry, then that may affect the samples as well. So, I mean, we do have guidelines which just really should be followed, and they should be all right.
Mm. We have seen in the lab a few lowish levels, not profound biotinidase, and we have gone and done a recollection request on those, and they have come back as quite normal biotinidase levels. So that gives us quite a fair bit of confidence in some ways that it is about the timeliness of transport and with the samples. There looks as though there is a few questions in here. So I'll go to the first one on this, which I think is a definite Holly question. What is the percentage of families who decline newborn screening?
I am unsure. I'm not sure if Mercy remembers the exact percentage, but we have seen quite a significant jump in the number of refusals. It's kind of correlates with COVID times. So yeah, there is quite a substantial increase in the number of declines we are receiving, but I'm not sure of the specific percentage. Mercy, can you recall?
Yes, roughly, I think up until COVID time, we had around 0.2%. That is roughly around 150 newborns has been refused to have screening. But I think after COVID, like how you said, Holly, the numbers are going really high. So it's roughly around 0.6% to 0.8% out of the 75,000 newborns born every year in Victoria. So it's roughly going up every year. So now I think around 0.8% is what we are looking at this time of the year.
Yeah.
If I may, it's also not universal across all the maternity service providers. It does vary. But I can see Joy, I think, wants to add to this answer. Am I correct, Joy?
I think Rhonda, Mercy, and Holly already answered that. Definitely, the refusal of the newborn screening is increasing. Hence, the importance of the before, as Holly mentioned, we have to introduce newborn screening as early as possible to couples, and so that they have also the time to reflect on it and also see the advantage. So it's sort of not just a one-off sort of introduction of newborn screening, and also during post-delivery, for example, it might be harder to introduce newborn screening for the first time because parents, as we understand, would be stressed and also would be thinking about other things, many other things regarding their baby and also the pain they're going through after delivery, so that it's better to have the introduction before in a relaxed state so that we also give them the chance to really think about newborn screening and the advantage of the screening for their babies.
Thank you, Joy. Now I've got a couple of other questions here. I think the question that I have is how many conditions do we now test for in Victoria? So officially, I think we're up to 35 conditions in Victoria. It's all detailed on the Commonwealth website. What is tested for, and so we now actually refer to that rather than maintaining our own list. But I might hand over just to Leah because she might have some comments because most of the conditions are metabolic, and so she sees a lot of fun here in the types of conditions.
No, I don't have the number either because we have been adding like non-metabolic ones as well. So
Yeah.
no.
Yeah. But certainly there is a lot of metabolic conditions, and biotinidase is the latest. There was galactosemia before that, MSUD, maple syrup urine disease, phenylketonuria, which is our original condition, newborn screening condition, the one where it all started in Victoria and all started for newborn screening, and MCAD, medium chain acyl dehydrogenase deficiency, are probably some of the common metabolic conditions that we are seeing each year. So there is another question here, and how long are the cards kept for? Is that for you, Joy? Is that for me or for Holly? Who would like to take that one?
Holly, you want to answer that?
Yeah, happy to.
Yeah.
So we store the cards, or the lab stores the cards for 2 years for quality assurance, and then they're stored indefinitely. However, families do have the ability to request to have their card or their child's card returned after the 2-year mark. We are currently in the process of fine-tuning an online system to request the card back. So that should be coming very, very soon. But yeah, for the time being, families can just email the lab and we can organise that request for them.
Yeah. The next question is thank you, Holly, I should have said. That was very clear. when a metabolic condition is picked up, how long do parents get notified of the result from VCGS? So when we have a newborn's positive screen, we actually refer that to a clinical team who then does the referral. So in this case, with the example of metabolic, we'll go to the RCH metabolic team. So I might hand over to Leah to answer that,
Yeah.
if that's okay.
The answer is immediately. So for metabolic conditions, we do recall the patients urgently. There are times when it can go up to 24 hours, but most of the time it's less than that. So for the more urgent conditions, we definitely recall them on the very same day. For the conditions that are less urgent, still important, of course, early treatment still, but then, wherein a few hours won't make a difference, recalling during the night versus recalling early in the morning, when that won't make a difference, then sometimes it will have to be in the morning. But definitely within the 24 hours anyway.
Thank you. I'm
Rhonda.
sorry, go Joy,
Yeah,
please.
thank you so much, Leah. And just to add on, it's also uh, from the clinical point of view, right, Leah, that sometimes you even have to ask the family and the baby to present in the emergency room because of the risk of the baby becoming very unwell.
Yes, so for the urgent ones, we definitely do that on the very same day, with urgent confirmatory testing and medical assessment.
Mm. So in the case of biotinidase deficiency, if I've said that we would have done a recollection on borderline results, how long do you think we really have in terms of, because this isn't defined by the Commonwealth Government yet or the HGSA, in terms of turnaround time for biotinidase, whether it's an urgent or a not? What would be your opinion on that, an appropriate turnaround time for a biotinidase deficiency? Sorry, throwing you on the spot.
All right.
Maybe hours, days, weeks, months might be easier.
Yeah, it hasn't been as well defined a timeline as with other metabolic conditions. So, like, say, for example, MSUD, it has to be before um a week, because even before then they would have presented already anyway. And with phenylketonuria, for example, that every single day you are affecting the brain. With biotinidase deficiency, I guess the clue that we have is that patients have presented as early as the 10th day of life, so around 2 weeks of life, which gives us a rough timeline in terms of our goal. On average, though, they will present at around 3 months. So I guess there is that variety still in terms of when they do start presenting, but definitely the earlier the better, because as we discussed today, like the moment that you already have those neurologic and in particular hearing vision defects, which are actually quite difficult to assess in newborns anyway. So it's really much better to start the treatment early. So if we recall early, then that gives us a better chance of preventing the symptoms from occurring at all.
Yeah, thank you. I may have missed, Leah, in your presentation. With biotinidase deficiency profound, how soon do you think that they're going to get that hearing loss or reduced? And as an example, is that within weeks?
No, not really. So it doesn't present as early as the seizures may or the dermatologic signs may. So it's a little bit later on, but still can
Okay.
be within months. So
Okay. Thank you. I'm sure there's a million other questions that people have about biotinidase and all these new conditions that we're adding. I think we will finish up the questions now, and I'd just like to say what we're planning on is to continue the 2 forum model per year, and the forums will be for an hour in length, and we'll keep trying to do the same format. We're predicting our next forum is on sickle cell coming up, and that will probably be in the new year, because this is our second forum for the year. I'd really like to thank Holly and Leah for joining today, and especially Leah for input. It's really excellent to be able to see the impact that newborn screening will have on the biotinidase deficiency, and we'll get to understand the incidence in Australia as well, or in Victoria, because we're the only ones doing it at the moment. So ahead of the game. Very nice. Mercy and Joy, thank you for joining to support in the background also. And thank you everyone for joining, and for everyone later who is going to log on. We're planning on having this recording up on our website as an information session. I wish you all a good evening, and thanks for attending. Much appreciated for us and all the babies of Victoria. Cheers. Good night.